Hi everyone, today I'll be going over my case following a geriatric cardiovascular concern. This follows a patient I saw in clinic the past week. FB, he's a 72-year-old Caucasian male. He presented to the clinic alone and he's a reliable historian. What's brought him in is he's had intermittent chest tightness for about a month. It comes and goes, doesn't seem to follow any sort of significant pattern. He does note it comes on when he's feeling a bit more stressed. He is working towards the culmination of an 8-year project, so it's finally coming to an end and he's feeling a bit of pressure as he gets that done. He is quite active with surfing, biking, and hiking as some of his favorite activities, and he doesn't have any incidental chest tightness or chest pain when he does any of those activities. He doesn't have any accompanying symptoms with it, like shortness of breath, dizziness, palpitations, diaphoresis, or headache. And he can't really correlate it with any other, diet. It's not brought on by any sort of foods. He doesn't have a history of gastroesophageal reflux disease or heartburn. He does have a history of hypertension that's been well controlled with hydrochlorothiazide 25 milligrams and lisinopril 20 milligrams daily. He has no other major health issues. His only other medication is the occasional sildenafil for erectile dysfunction. He does have a family history of coronary artery disease and high blood pressure in his father and both of his grandfathers, both maternal and paternal. And his maternal grandfather has a history of coronary artery disease and MI. He's not sure of the date or the age at which his maternal grandfather had the MI, though. He doesn't have many other risk factors. Like I said, he's quite active. He has no history of diabetes, no smoking, doesn't drink alcohol, and no history or current use of illicit drugs. The main thing that's going on for him is a high stress level as he approaches the culmination of this 8-year project. Other medical issues, very benign things like acne rosacea and his erectile dysfunction, which he manages with sildenafil. He's up to date on his colonoscopy, no other relevant surgical history. He has a history of penicillin allergy as a child, but who knows if that's actually a true allergy. No other concerning allergies there. And he's up to date on all of his medications. He's very diligent about getting his flu vaccine. He's had his RSV vaccine, so he's in a good standing there. Lives at home with his wife. He's been married many years. And no other real concerning family history besides the coronary artery disease, MI, and hypertension. Review of systems is pretty non-contributory. The only thing that's really going on is that intermittent chest tightness. Like I said, he has no accompanying shortness of breath, no lower extremity edema, no palpitations, no shortness of breath, no chest pain with pressure onto the chest, dizziness, headache, weakness, or syncope. His vital signs look great today. His blood pressure is 123/85, pulse of 61. Everything else non-contributory. Because he's having chest tightness, we did get an EKG in the clinic, and it demonstrated a first-degree AV block with a normal sinus rhythm. So we don't do anything for AV block, but because there was a finding, we will refer him to cardiology for an extended Holter patch monitoring to see if there's anything else going on, and then he will also be referred for coronary. He will also be referred for if I could find it in my notes here, apologize. CT coronary calcium scoring with the cardiologist to assess his risk, especially with his family history of CAD. Additionally, we will want to calculate his ASCVD risk. He's not on a statin. The most recent lipid panel we had for him, which we could use to calculate the ASCVD risk score, was from February of 2023. So we did repeat that the day he was in clinic, so we can have a more up-to-date ASCVD risk score. But given his most recent labs that we had and his history of non-smoking and his blood pressure history, his calculated 10-year ASCVD risk was 18.9%, whereas his ideal optimal risk would be 15.1%. At the time of this previous scoring, he wanted to avoid statin therapy if possible and treat his higher ASCVD risk score with lifestyle modifications alone. But might be something that we want to reconsider depending his more recent labs and his new calculated risk. He may need to begin a statin therapy just to optimize his ASCVD risk and prevent any sort of major issue. On physical exam, pretty unremarkable. On auscultation of the cardiac exam, he did have a few occasional misbeats, but no murmurs, gallops, or rubs. He had no peripheral edema, no jugular venous distension. Other than that, everything was very normal. So what we could my primary diagnosis is a stable angina. We may also consider anxiety-induced chest pain, and a can't miss diagnosis would be an acute coronary syndrome like an MI. So not really too concerned about an MI, especially with the encouraging EKG, but it's something that always needs to be in the differential. Like I said, for diagnostic tests, we got the EKG, which was reassuring, and we will refer to cardiology for additional monitoring, like the Holter patch and the CT coronary angiogram scoring, and we will follow up to determine if further treatment is necessary from there. In addition to that, we'll be getting labs. We'll get his lipid panel. We can also get a CMP and a CBC just to make sure that his electrolytes are looking fine and that there's no blood issues like an anemia or something like that. So his treatment for today, we'll get the labs, we'll send him to cardiology, encourage his continued healthy lifestyle, and we may want to consider a prescription of nitroglycerin sublingual tablets for him to have. His blood pressure wasn't very high today, and he's already on 2 blood pressure medications, so we don't want to drop him too low, but it's important for him to have this at home if he does have angina that's not going away, and that'll be a big part of the education on how to take that properly. For example, he should take 1 sublingual tablet under the tongue at the onset of his chest pain and wait 5 minutes before taking a second tablet. If he still has pain after the second tablet, he should call 911 and take the 3rd tablet and then go with the EMTs. A very important thing if we're going to prescribe nitroglycerin for this patient is for him to ensure he has not had his sildenafil within 24 hours of his nitroglycerin to avoid severe hypotension. I would also recommend he take his blood pressure before taking the nitroglycerin to ensure he's not going to drop himself too low. We will call him with lab results and discuss if statin therapy is indicated, and we should also plan to have him follow up in clinic in a couple of weeks once he's had his Holter monitoring done, and he should be advised to call 911 immediately if he has persistent chest pain, shortness of breath, intense sweating, or any other concerns to ensure we're not missing something severe. Thanks for listening.